thyrotoxicosis, which is extremely relevant from a pediatric endocrine perspective and which has got significant implications in terms of diagnosis and management. So we'll try to cover this about various aspects of the thyroid disorders. So we'll start off with this case, 17-year-old girl with neck pain who had a high FT4 and low TSH, was advised methimazole, and she did not have any eye signs or goiter. Now, this is a common presentation, and unfortunately, this child was started on methimazole. While if we look at the clinical picture, it was less likely to be Graves' disease, and in this scenario, a possibility of thyroiditis should have been considered. So, a thyroid scan was done, which showed a reduced intake in that perspective. You can watch on YouTube. So very importantly, therefore, it is that we should really look at nuclear scan in individuals who have got a feature of thyrotoxicosis, especially if their FT4 levels are not very high, if they do not have an eye sign, if they do not have a goiter in that regards. All of you can go and have a look at our website, learning.growsociety.in. You can go and have a look at our web portal, which has got a lot of learning resources which are there. Look at our fellowship courses which are there in that perspective, and the courses including the courses for fellowship and PG courses as well. You can also attend many of our free series which are there in terms of the lecture series, journal clubs, and our publications which are accessible, and also in terms of our app which helps in terms of diagnosis and management at the right time. So today we're going to talk about thyrotoxicosis. I'll touch base initially about the overall physiology. Then Dr. Alapan will talk about the etiological aspects, and then we will have again discussion about assessment management, and Dr. Sandeep will take up forward from some of the Q&As in that regards. So the key questions in thyrotoxicosis are, is it really thyrotoxicosis? What is the status, whether it's a TSH dependent or independent thyrotoxicosis? What's the cause and how do we treat? So as discussed, thyrotoxicosis has effects on every part of the body. So the most common symptom that we see as children, or of course the pediatric patients will come us with, is a thyroid swelling and a protrusion of eyeball. But there are other symptoms like tremor and anxiety because of sympathetic hyperactivity. That is something which is there. On the long term, it can have an effect on the bone, causing low bone mass. Tachycardia, atrial fibrillation are rare in children, but can happen in extreme scenarios, particularly if they are presenting to us as a thyrotoxicosis storm. There could be a high output failure if the heart pumping becomes too much. Fever, unexplained fever is a common presentation which we have to look at. And these children are tall, but along with that, they have an advanced bone age. So they have a compromised height from that perspective, and hyperdefecation may also be there. So most common symptoms that we will encounter is usually eye signs, along with a thyromegaly, and then weight loss, tremor, and sympathetic symptoms are also very, very important. So thyrotoxicosis should be considered in any child who has got significant weight loss, who has got frequent motions, tremors, eye signs, periodic paralysis, and polyuria. Now, while I'm emphasizing on eye signs and that being a marker of Graves' disease, we should understand is that more patients of thyrotoxicosis without eye signs will have Graves' disease as against thyroiditis. So just the absence of thyromegaly, just the absence of eye sign does not exclude Graves' disease. It makes the chances of thyroiditis a bit more. That is the only thing you have to remember about. So fatigability, worsening of school performance, and it's also been associated with myasthenia gravis, which becomes important. Now, in very, very acute scenario, the thyroid is uncontrolled, especially if somebody goes for surgery, or if there some radioactive treatment is there, the patient goes into what is known as thyroid storm. In that scenario, there could be a refractory thyrotoxicosis resulting in cardiac failure, hyperthermia, and that could be a life-threatening condition for which we need to be really worried about, because otherwise the patient will go into a comatose state and there could be a high chance of death from that regards. Now, when we talk about thyroid assessment, we know that for thyrotoxicosis, as I discussed earlier, we need to look at both FT4, TSH, as well as T. Anybody whose TSH is thyrotoxicosis is there, TSH should be low and T4 is high. T3 is the last one to be raised, but sometimes because of T3 toxicosis, your T3 may be disproportionately high. So thyrotoxicosis, you have to look at all of the three parameters together. Do not ignore T3, because then you won't know whether it's a subclinical thyrotoxicosis which does not need treatment, or T3 toxicosis where treatment is definitely required. Now, once we know that this is thyroid, the issue, the next issue would be what is the underlying cause. And for that, we need to look at both FT4 and TSH together. Anybody who has a high FT4 should have a zero TSH. or an undetectable TSH. This is classically a case of thyrotoxicosis. If FT4 is high and TSH is detectable, that is meaning that there is either a TSH receptor adenoma, which is very, very rare in children, or there could be a thyroid hormone resistance, which also is rare. So always repeat that scenario from that perspective. Now, another important thing to look at is when should you think of thyroiditis versus Graves' disease. And in that regards, the thing that you can look at are antibodies. TPO antibodies is not a very, very good marker, but it will give you a clue towards thyroiditis. There will be no eye sign of goiter. It's a milder disease. The FT4 levels are usually less than the double of the upper normal range. So if you have an upper normal range of 22 picomoles per liter, this will be somewhere around 25, 20. While in Graves, the levels may go up to 50, 55. They are much, much higher. So very high level will suggest Graves because ultimately you don't have that much thyroid to be released from the gland from that regards. While if you have a TSH receptor stimulating antibodies, you will have other features like eye signs and goiter. Remember that the antibodies which are acting in the eyes may be different completely because they are working on different antigens, but often they coexist and they will be more severe levels are typically above double the upper limit of thyroid hormone, and the uptake on scan will be high. And then you have to treat them with antithyroid drugs. So clearly, if you have a much more severe onset, you have got eye signs, you have got goiter, your FT4 is very, very high, you should think of Graves' disease. While FT4 is not that high, there is no goiter, there are no eye signs, there is no bruit, it is more likely to be thyroiditis. Especially if there is tenderness in the neck, start thinking, as Dalapan said, about subacute thyroiditis. And if it's extreme tenderness, then you should think of acute thyroiditis or a pyogenic infection in that regards. Usually, we would not recommend radionuclide scan in everybody or the TSH receptor antibodies, but if you are in doubt, then you can look at these tests to get the final diagnosis in that regards. Now, anybody who has got no goiter and the onset is below 1 year of age, the likelihood of Graves' disease becomes extremely unlikely, and then you have to think of some other cause, especially if there is no eye signs as well. TSH receptor antibody is a very good test. It tells us about the autoimmunity status. But what you need to remember is the TSH receptor antibody may be stimulatory and inhibitory. And the antibody we are measuring is actually an immunoassay. It is not a bioassay. So while TSH stimulatory immunoglobulin TSI, which is a bioassay, is a better marker of thyroid production or increased activity, it is extremely expensive, takes time, it's not routinely available. So we measure TRAb, and if TRAb is positive in a characteristic clinical scenario, in that setting, you can consider basically that this is more likely to be Graves' disease than anything else. So this is an immunoassay in which you are competing to the TSH binding, and this can be both stimulatory or inhibitory from that regards. While for bioassay, you have to actually look into particular cells of cultured thyrocyte cells where TSH antibodies are going to increase the thyroid production. This is something which is extremely expensive, not easily available. But TRAb antibodies are now being used as the first line to differentiate Graves versus thyroiditis. So the chances of needing a scan is less. So if you are wanting to distinguish and you do a TRAb is very high, no need to do any further. If your TRAb is negative and your suspicion of Graves is more, then you can do for scan. So the chances of needing a scan, which is more difficult, also exposing to radiation, is now less with the use of TRAb antibody in that regards from that perspective. The thyroid scan, we all know we can use the iodine 123, but most people now are using technetium 99, and especially if there is no eye sign, goiter, and TRAb is negative. However, one condition where a scan should be done always is if there is a solitary nodule. If there is a solitary nodule, you want to make sure whether it is a hot nodule, a warm nodule, or a cold nodule, because that is going to determine the need for FNAC and the risk for malignancy. So that becomes extremely important. So you may find no uptake on thyroid scan, which is thyroiditis. You may find diffuse uptake, which is Graves' disease. You may find a toxic hot nodule in which you have got uptake in the nodule, and the rest all area there is no uptake. Or you can find the MHG, or really you can find a warm nodule in which there is uptake in the nodule, but the surrounding areas also have got certain uptake in that regards. Thyroid ultrasound has got limited role, but it may be helpful in terms of characterizing your thyroid nodule if it is there, from that perspective. Some people talk about vascularity as a marker of increased production, but that's not something which is extremely well proven. So it's not a good tool to differentiate between thyroiditis versus Graves' disease in that regards. So nuclear scan is ideally the best test, but we may also do TRAb antibodies if that's easily available to you. You may avoid these if there are clear-cut goiter or eye signs or the FT4 is extremely high. If the uptake is increased, this is more likely to be a solitary nodule. If there is a toxic MNG, you will find multiple nodules. If there is diffuse uptake, this will be like Graves' disease. If the uptake is decreased and there is tenderness, this is more likely to be a subacute thyroiditis. If there is no tenderness, this is going to be a chronic lymphocytic thyroiditis. So based upon the level of FT4 elevation, based upon the size, and you can all go and have a look at our website, learn.doctorid.in, explore our books and our application in that perspective. So